Good morning. This is Dr. John Bennett from Miami Beach, home of Neurosurgical TV. We are honored with the presence of Victor Hugo Perez Perez, a world-famous neuroanatomist as well as a neurosurgeon. And I'll let Juha give the proper neurosurgery introduction. Good morning, Juha.
Hello everybody. Welcome, especially Victor Hugo Perez Perez. So I give a short introduction, and you can see my screen now.
Not yet.
Yes.
Now it's okay now.
Oh,
Okay, now ready.
Professor Victor Hugo Perez Perez from Mexico City. Mexico belongs to one of the most active international teachers of neurosurgical anatomy, like you have seen just before this presentation. John Bennett showed the series of 12 webinars for Latin America in Spanish. So Professor Victor Hugo Perez Perez became medical doctor 1988 in Mexico, and then neurosurgeon 1993, also in Mexico. And then he made a one-year skull-base fellowship in Detroit, Wayne State University in USA. And since '95, he has been working as brain and skull-base surgeon at National Medical Center and at Mexican Social Security Institute. Professor Victor Hugo Perez Perez has been researcher in neuroanatomy since 1990 at the Forensic Sciences Institute, Mexico City. This means more than 30 years of anatomy learning, and he's making what I have seen, most wonderful cadaveric specimen and their dissections in brain, skull base, and spinal channel and spinal cord also. How to become a good neurosurgeon? This is a question many times have asked. So train hard, and one of the good ways is follow the way Professor Victor Hugo Perez Perez has done and is doing. Very good training and learning anatomy all the time. Like I mentioned, more than 31 years studying anatomy. He has been teaching high number of residents and fellows and students around the world, has publication on neurosurgical anatomy, and very active in congresses, live courses, and especially now in webinars around the world. He's member of many societies and has been teaching us also here in China, Chengzhou, at Henan Provincial People's Hospital before COVID time. Now it is difficult to organize foreign visitors to China. So you should train your best young people. They should become better than you. This is what I always show this slide. The younger generation is always growing better and flying higher than we. So I welcome you to this very interesting neuroanalytical session. Thank you. Thanks. So, Victor,
Thank
word
you.
is yours.
Thank you. Thank you. Let me share my screen. Okay. Can you see it?
Yes, but not full size yet.
Okay, let me try again. Okay, now I think it's ready.
Yes, perfect.
Okay, thank you very much. So let me tell you something. This is a big honor for me to be invited by Dr. Juha by Dr. Binshu and Takashi Kon. This is a great pleasure to be with all of you.
谢谢John 提供的平台，谢谢友好教授、徐斌教授的盛情邀请，非常荣幸能在这个平台和大家介绍我的一些工作。
I'm going to talk about the art of anatomy from brain to spinal cord. So what I have been doing for almost 31 years is to inject some brains and also spinal cords. As you can see in this short video, I am injecting the superficial veins of the lateral aspect of this brain, the left aspect of the brain. So once you have injected this brain, you are going to have a very good specimen to study anatomy. So for me, neuroanatomy is an art. The musician requires great sensitivity for the development of his art. In the same way, the neurosurgeon requires knowledge of neuroanatomy to guide his hands in the delicate art of removing a brain tumor or clipping an aneurysm. So in this video, I injected the arterial, the middle cerebral artery. And as you can see, this model is very good to study, not only the veins and arteries, also the parenchymal brain. So first of all, I want to talk about some aspects of the arterial supply to the brain. So this is divided into groups, the supratentorial and infratentorial arteries. The supratentorial arteries include the supraclinoid portion of the internal carotid artery and its anterior and middle cerebral artery, ophthalmic, posterior communicating, these are the posterior communicating arteries, the anterior choroidal branches, the components of the circle of Willis, which in the posterior midline includes the basilar apex, this is the basilar apex, and finally the posterior cerebral artery. The origin of all of these arteries is located deep under the center of the cerebrum, and their proximal trunks are relatively inaccessible because they course in deep clefts, like the sylvian or interhemispheric fissure, or in the basal cisterns between the brain stem and temporal lobe. The segments of the internal carotid artery. The ICA is divided into 4 parts. The C1 or cervical portion extends from its junction with the common carotid artery to the external orifice of the carotid canal. The C2, as you can see in this drawing, or petrous portion courses within the carotid canal and ends when the artery enters the cavernous sinus. Here we have the petrous in an specimen. The C3 or cavernous portion courses within the cavernous sinus and ends where the artery passes through the dura mater forming the roof of the cavernous sinus. Here we have the cavernous sinus, and these are the cranial nerves involved with the cavernous sinus. And the C4 or supraclinoid portion begins where the artery enters the subarachnoid space and terminates at the bifurcation into the anterior and middle cerebral arteries. Here we have the optic nerve, and in this side begin the supraclinoid carotid artery. The C4 begins where the artery emerges from the dura mater, forming the roof of the cavernous sinus. This is the supraclinoid portion. It enters the cranial cavity by passing along the medial side of the anterior clinoid process and below the optic nerve. It courses posterior, superior, and slightly lateral to reach the lateral side of the optic chiasm and bifurcates below the anterior perforated substance at the medial end of the sylvian fissure to give rise to the anterior cerebral artery and middle cerebral artery. This is the circle of Willis. Here we have the posterior cerebral arteries, and these are posterior communicating arteries and its branches, and their branches coming from these big arteries. The premammillary artery is the largest branch that arises from the posterior communicating artery. This is the posterior communicating artery. Here we have this beautiful artery. It enters the floor of the third ventricle in front or of or beside the mammillary body. Here we have the mammillary body. An optic tract. There are commonly 2 or 3 branches terminating in the premammillary area, but only the largest branch is referred to as the premammillary artery. The premammillary artery has also been referred to as the anterior thalamo-perforating artery. The premammillary artery most commonly originates on the middle tier of the communicating artery, but can also arise on the anterior or posterior tier. It supplies the posterior hypothalamus, anterior thalamus, posterior limb of the internal capsule, and subthalamus. The ophthalmic artery is the first branch of the C4. Most ophthalmic arteries, this is the ophthalmic artery. Most ophthalmic arteries arise below the optic nerve. This is the optic nerve, and this artery arises below it. In the supraclinoid area, above the dural roof of the cavernous sinus, and passes anterolaterally below the optic nerve to enter the optic canal and orbit. 8% of ophthalmic arteries originate within the cavernous sinus. It is rarely absent. The ophthalmic arteries uncommonly give rise to intracranial perforating branches, and if present, these branches run posteriorly and are distributed to the ventral aspect of the optic nerve and chiasma and the pituitary stalk. In this side, we have an overview of the cavernous sinus. Here we have the supraclinoid carotid artery, the third cranial nerve, and this is the intercavernous sinus. And here we have the diaphragm of the sella of the pituitary gland. Here we have the stalk of the pituitary gland. The anterior clinoid process, posterior clinoid process. Posterior communicating artery. The posterior communicating artery forms the lateral boundary of the circle of Willis, arises from the posteromedial surface of the C4, approximately midway between the origin of the ophthalmic artery and the terminal bifurcation. Here we have an hypoplastic posterior communicating artery. Roton used to say that posterior communicating artery, the hypoplastic of this artery, is less than 1 millimeter of diameter. It sweeps backward and medially below the tuber cinereum, above the sella turcica, and slightly above and medial to the oculomotor nerve to join the posterior cerebral artery. So here we have a hypoplastic posterior communicating artery, and in the other side also we have a hypoplastic posterior communicating artery. This is the basilar artery, the superior cerebellar artery, and P1, P2 of posterior cerebral arteries. Optic nerves, mammillary bodies, and anterior cerebral arteries. Anterior choroidal artery. The classic reported clinical features of occlusion of the anterior choroidal artery are contralateral hemiplegia, hemianesthesia, and hemianopsia. The contralateral hemiplegia and hemianesthesia to all sensory modalities results from infarction in the posterior two tiers of the posterior limb of the internal capsule and the middle tier of the cerebral peduncle. The homonymous hemianopsia of varying degrees results from interruption of the supply to the origin of the optic radiations, the optic tract, and part of the lateral geniculate body. Here we have the origin of the anterior choroidal artery. This is anterior choroidal artery, and this is the other one. So here we have the mammillary bodies, optic nerves, and lenticulostriates arteries coming from M1 of the middle cerebral artery. The anterior cerebral artery is the smaller of two terminal branches of the internal carotid artery, arises at the medial end of the sylvian fissure. Here we have the anterior cerebral artery, supraclinoid carotid artery, middle cerebral artery, lenticulostriates arteries, optic nerves, lateral to the optic chiasma and below the anterior perforated substance. It causes anteromedially above the optic nerve, as you can see in this picture, or chiasm, and below the medial olfactory striate to enter the interhemispheric fissure. Near its entrance into the fissure, it is joined to the opposite ACA by the anterior communicating artery and ascends in front of the lamina terminalis. Here we have the lamina terminalis to pass into the longitudinal fissure between the cerebral hemispheres. This is a beautiful picture in which we can see optic nerves, anterior clinoid process, supraclinoid carotid artery. This artery continues as the middle cerebral artery, and here we have the anterior cerebral artery. Here we can see some lenticulostriates arteries. So in this another picture, we can see this anterior cerebral artery in front of the optic chiasma and the optic nerves. Beside, we have the supraclinoid carotid artery, middle cerebral artery, and this short arteries, lenticulostriates arteries. Basilar artery, vertebral arteries, superior cerebellar artery, and posterior communicating artery. Third cranial nerve between the posterior cerebral artery and the superior cerebellar artery. Here we have, in this picture, we can see the anterior cerebral arteries and the anterior communicating artery and the branches that are coming from these anterior communicating arteries. The microvascular anatomy of the anterior communicating artery shows great variability in its shape, diameter, and length, presenting fenestrations, duplication, and triplication. The anterior communicating artery has an average length of 6 millimeters with a diameter of 0.8 millimeters to 4 millimeters, an average of 2 millimeters. A single anterior communicating artery is present in 60% of the cases. The A1 is a favorite site on the circle of Willis for hypoplasia. A1 hypoplasia has a high rate of association with aneurysm. It is found with 85% of anterior communicating artery aneurysm, and it is the only anatomic variant that correlates within the location of cerebral aneurysm. Here we have a video in which I want to show you the anterior communicating artery in here. Then the A1 segment, A2 segment, the left side, right side, and this is a very short and very short anterior communicating artery. As you can see, they are also joined. Both anterior cerebral arteries are joined in a very short space. So here we have some branches that are coming from anterior communicating artery. So if you want to divide these some anterior communicating artery, you should to be care of these small branches that are coming from this segment of the anterior communicating artery, because one of these branches is the anterior hypothalamic artery. So this hypothalamic artery is going to supply the anterior nuclei of the hypothalamus. This is another variation of this anterior communicating artery. This is like we have a fenestrating artery. The fenestrated anterior communicating artery is found in a low percentage of cases. A1 segment send branches to the anterior perforated substance. Most of these arteries arise from the proximal half of the circle of Willis. Here we have these small branches coming from anterior cerebral artery. This is another picture in which we can see a fetal variant of a posterior communicating artery. When we talk about fetal variant, the posterior communicating artery is bigger than the P1 segment of these posterior cerebral arteries. It means that the main supply, the main flow to the posterior cerebral artery is through the posterior communicating arteries. In this specimen, both posterior communicating arteries are fetal variant. And you can see in here, the diameter of the P1 in both sides is lower than this one. In this video, we can see these optic cranial nerves, the chiasm, and here we have some arachnoid, and I'm going to divide the interhemispheric fissure to look much better this segment of the anterior cerebral arteries. You could have many advantages if you inject these specimens, because it's very easy to differentiate between very small branches, very small perforating arteries, and differentiate with the arachnoid trabeculae. Here I'm going to separate the interhemispheric fissure and look for the A2 segment of this anterior cerebral artery. So for example, in here, you can see a small branch that is coming from this short anterior cerebral artery. So if you decide to divide this artery to have a better looking of suprasellar tumor, take care with these small arteries that are coming from anterior communicating arteries. And here we are going to find another interesting artery. This artery, this one, that this is a Hübner recurrent artery of Hübner, that is coming most of the times in this segment, A2, anterior cerebral artery in this segment. This is a recurrent artery of Hübner. So here in this picture, we have another very short anterior communicating artery, A1, anterior cerebral artery, the middle cerebral artery, optic nerves, the third cranial nerves, and you can see in here the morphology of these posterior cerebral arteries. One of them is small, and look at the difference between this P1 segment and the other one. The posterior part of the circle of Willis, this is one of the most difficult sites to approach surgically. The complex series of perforating vessels surrounding and arising from it, and its intimate relationship to the extraocular nerves and upper brain stem. Its branches are exposed in surgical approach to the basilar apex, tentorial notch, lateral and third ventricles, and inferior temporal. So, of course, this is a very delicate vascular structures. And look at this. In here we have a hypoplastic P1 and fetal variant in the posterior communicating artery. The superior cerebellar arteries And I want to tell you that these very beautiful descriptions of these arteries has been taken by this supplement of Albert Rotten in Neurosurgery, volume 51, supplement 1 in October. The posterior part of the circle of Willis. This is one of the most difficult sites to approach surgically. The complex series of perforating vessels surrounding and arising from it and its intimate relationship to the extraocular nerves and upper brain stem. Look at this video. And this we can, we are very sure that the delicate and complex series of these perforating vessels. So here we have the posterior thalamic arteries and some others perforating branches. Tear cranial nerves, mammillary bodies, look these beautiful branches of the upper basilar artery. So here we have also another video to show these beautiful arteries coming from posterior cerebral artery in P1 and P2 segments. This is a posterior communicating artery and the branches from posterior communicating artery. Here we have two tear cranial nerves, this and the other one. The fetal configuration in which the proximal PCA is small and the posterior communicating artery provides a major supply to the posterior cerebral artery and is larger than the P1. Here we have another picture in which we can see the very small P1 in the left side in this specimen. And also in the other side is smaller than the posterior communicating artery. In both sides, we have a fetal configuration. A hypoplastic arterial segment is defined as one having a diameter of 1 millimeter or less, like you can see in this picture. So the interest in learning the microsurgical anatomy is a success of the removal of big tumors like this meningioma. So the orbit is in the anterior and medial cranial fossa and inferiorly with the pterygopalatine and infratemporal fossa, the nerves and vessels entering and exciting the orbit pass through the optic canal and superior orbital fissure, which are partially surrounded by an annular tendon from which the rectus muscle arises. Here we have the skull base. And the orbit can be approached surgically from anteriorly through the face and conjunctiva and or through any of its walls and from intracranially. The most common neurosurgical approach are directed through the superior and lateral walls to lesions located deep in the orbit near the apex or involving the optic canal, superior orbital fissure, and adjacent areas. So here we have a big meningio and the resection complete resection of this CC surgical procedures. These are some invasives. This kind of surgery is very invasive. Maybe in some years, or maybe right now, in the principal or more in most of the advanced countries around the world, this kind of surgery can be replaced by endoscopic treatment. But now we do this surgery, especially for malignant tumors. In this, I am working with the ethmoid. I am drilling the ethmoid bone in order to advance for the tumor. Yeah. With some instrument, I am taking away this bone. In here, you have to take care with the ethmoidal anterior and middle ethmoidal arteries. But if you have a big tumor in the anterior skull base, this is a very good tip, a very nice tip, to coagulate these ethmoidal arteries, because they are supplying this kind of tumors. This is a picture of these big tumors, and this is the anatomy of the orbit. I told you about the ethmoidal anterior or middle ethmoidal arteries that are coming from the ophthalmic artery, and this is these ethmoidal arteries. These ethmoidal arteries supply these big tumors, contribute to the supply to these big tumors. This is a posterior surgical treatment. And here we have another view of this middle cerebral, the anterior and middle ethmoidal arteries. The globe is surrounded by a group of muscles in case, in fact, to allow free movement of the globe and muscles, but limited at the extremes by ligamental structures to prevent excessive morbidity. Here we have another short video in which we are removing this bone. The ophthalmic artery usually arises just above the cavernous sinus from the medial half of the superior aspect of the anterior vein of the internal carotid artery. Its origin is located under the medial part of the optic nerve, just behind the optic canal. In the optic canal, the ophthalmic artery courses within the optic sheath or below the optic nerve and through the annular tendon. It exits the optic canal and penetrates the optic sheath to enter the orbital apex on the inferolateral aspect of the optic nerve. In this video, I found the absence of the ophthalmic artery. So look at this. In this right side, we have the supratentorial segment of this internal carotid artery, and here we have the origin of the ophthalmic artery. In the left side, I dissect this cavernous sinus, Here we have the inferior pituitary artery. And as you can see, we do not see, I didn't find the origin of the ophthalmic artery. As Roton said, this is very rare, but can be seen in some specimens, like in this video, like in this specimen. The third cranial nerve, some small arteries coming from the intracavernous portion of the internal carotid artery, and the cavernous sinus. The arterial relationships are especially complex with the vertebral and basilar arteries, having relatively inaccessible segments deep in front of the brain stem and the major cerebellar arteries coursing in relation to multiple sets of cranial nerves before reaching the cerebellum. The cortical surfaces are divided on the basis of the structures they face, or along which may be exposed. To make this description more readily applicable to the operative setting, the first surface, the tentorial surface, this is tentorial surface. The suboccipital surface is located below and between the lateral and sigmoid sinuses, and it is exposed in a suboccipital craniectomy. And the third surface, the petrosal surface, faces forward toward the posterior surface of the petrous bone and is retracted to expose the cerebellopontine angle. Here we have the cerebellopontine angle. The suboccipital surface located below and between the lateral and sigmoid sinuses is the most complex of the three surfaces. Operative approach to the fourth ventricle and most cerebellar tumors are commonly directed around or through this surface. The lateral walls of the incisura are formed by the medial aspects of the cerebellar hemispheres, deep clefts. The vermohemispheric fissures separate the vermis from the hemispheres. This is the vermis and hemispheres and the brain stem. The petrosal surface, the petrosal or anterior surface faces the posterior surface of the petrous bones, the brain stem, and the fourth ventricle. The lateral or hemispheric part of the petrosal surface rests against the petrous bone and is retracted to expose the cerebellopontine angle. The median or vermian part of the petrosal surface has a deep longitudinal furrow. The anterior cerebellar incisura that wraps around the posterior surface of the brain stem and fourth ventricle. The lateral recess and cerebellopontine fissure. The lateral recesses are narrow, formed by the union of the roof and the floor. They extend laterally below the cerebellar peduncles and open through the foramina of Luschka. Here we have the foramen of Luschka into the cerebellopontine angles. In this picture, you can see the choroid plexus and the lower cranial nerves. Each lateral recess opens into the cerebellopontine angle along the cerebellopontine fissure. This V-shaped fissure is formed by the folding of the cerebellar hemisphere around the lateral side of the pons and the middle cerebral peduncle. The ICA is intimately related to the lateral recess and the foramen of Luschka. Here, the foramen of Luschka, perforating branches, and the cerebellopontine angle. And the basilar and vertebral arteries give rise to many perforating branches that reach the floor of the fourth ventricle. The choroidal branches of the ICA supply the portion of the choroid plexus in the cerebellopontine angle and the adjacent part of the lateral recess. So in this video, we can see the segments of the posterior inferior cerebellar artery. This artery is very interesting because it has a very long trajectory in this part of the cerebellum. Vascular relationships. The pica is intimately related to the inferior half of the roof and supplies the choroid plexus in the roof and the medial part of the lateral recess. So in which, in some or several specimens like this, I have found several variations of this pica. Sometimes very short, sometimes coming from vertebral artery, sometimes coming from the inferior part of the basilar artery. The effects of neural injury. This is a short video in which I am showing the splitting of the vermis, resection of part of the hemisphere, removal of the tonsil, opening of the inferior medullary velum, separation of tumor from the floor and roof, dissection in the region of the cerebellar peduncles and deep cerebellar nuclei, and retraction or removal of the flocculus. Horsley pointed out the large amounts of cerebellar tissue could be sacrificed with little or no demonstrable loss of function. Now, this is not the case. We have to take care to remove parenchymal tissue for avoiding some lesions. This is another beautiful picture in which I found a hypoplastic vertebral artery in the right side, and in the left side, this artery continues as the basilar artery. This basilar artery divides into posterior cerebral arteries. These are the posterior communicating arteries. These are the arteries coming, perforating branches, and some of the large branches that are coming from the basilar artery. So again, this is a short video to show the injection of the lateral aspect of this brain. This is really beautiful, and not only beautiful, also very useful to know the real anatomy of the vascular supply and the draining through these important veins and beautiful veins. The Sylvian vein, the Trollard vein, and the vein of Labé, with a very good anastomosis between these three very important veins of the lateral surface of the brain. So here we have another beautiful picture showing the vascular supply through the middle cerebral artery and the 12 segments of this complex middle cerebral artery. Okay, here we have another video to show the absence of one posterior communicating artery. In this, in the left side, we have this posterior communicating artery, but in the right side, I didn't find this posterior communicating artery. So this is also a rare variation of the circle of Willis, the absence of a posterior communicating artery. Superior part of basilar artery, posterior cerebral arteries. Okay, let me show you this this other beautiful picture in which we can see the adenohypophysis and the neurohypophysis, the division of the two principal parts of the hypophysis, anterior and posterior, also known as neurohypophysis. And the supply of this hypophysis coming from the branches that are rising from the intracavernous portion of this carotid artery. This is a posterior view. Here we have the clivus and some in color blue, the sinus, the intercavernous sinus. Here we have a big tumor. Look how this tumor displays these arteries. So that's the reason we should know this brain anatomy and its supply to avoid damage of the principal or the main arteries that are located and displaced for this very big tumor. So another dissection is the superior sinus, the superior longitudinal sinus. So in here I am doing a resection of the dura mater to show you the superior longitudinal sinus. So this is a lacuna and some veins okay. Knowing this anatomy is very important to avoid hemorrhage in this in the tumors that are coming from this side of the brain. So if you have the possibility to make a dissection in this region, like in this case, you can avoid damage to this delicate venous drainage system. And now here I'm going to show you this. This is a short video. In this, I want to show you the beautiful arteries that are coming from P1. I invite you to see these beautiful arteries in YouTube. Thanks. This is another beautiful picture to see these complex arteries to the brain. I am also doing some skull base made from resin, and these cranial nerves are made from silicone. And in this kind of models, we can work drilling like in an anterior petrosal approach to find the Kawasse's triangle and to exercise. This is a good exercise, anatomical exercise to know much better the skull base. Okay, let me show you in this dissection. We have the white matter association fibers, the geniculate body, the lateral geniculate nucleus in this, and the anterior choroidal artery supplying this anterior lateral geniculate nucleus. Please, sorry, just 10 seconds. Erika. Ven rápido. Ve aquí a la puerta de aquí a un lado. Diles que si pueden bajarle a su música, que estoy dando una plática a nivel internacional, por favor. Okay, let's continue. I am doing also some cervical models made of resin to know the anatomical aspect of the bone in this cervical model, and in this we can see the spinal cord, the cervical spinal cord, and the vertebral artery. And this dissection is very useful to know the relationships between these arteries, these nerves, and the bone and the cervical vertebrae. Here we have the lateral aspect and the anterior aspect of this cervical spine. So look, if you are going to put a screw in the lateral mass of this cervical vertebra, take care, because if you do not realize, or if you do not make this kind of surgery in the precise site, you can damage the vertebral artery, also these nerves. So in this model, this is an exercise to make the perforation, the hole in this lateral mass. And then after I am putting this tube, and look, if you go to other side, you can damage this artery, and you can make damage also these nerves. So want to show you again, because this is really important to know. This screw should be put in the correct way. Look, if you go to other side, you can damage nerve and also the vertebral artery. In this video, in this short video, I am showing you how to collocate the screws in the atlas, in the first cervical vertebra, and the relationships between the nerves and the vertebral artery. Maybe some years ago, maybe 15 or 18 years ago, there was a congress organized in El Salvador, Central America. So I talked with the legendary and great brain surgeon, Albert Roton. I asked him if he was doing research, a study of the vascular supply of the spinal cord. And he told me that no, it was not of interest for him. He was doing a study of the head, not below the brain stem. So that time I thought that it was very important to work with the surgical anatomy of the spinal cord. So I began to inject very small arteries. This is a thoracic artery, and it's not easy to inject them, but the results are impressive. So we can study in these specimens all the arteries coming from these very small arteries, most of them less than 0.3 millimeters. It's very important to know also the anatomy of the spinal cord, cranial nerves, and also the lateral mass of the cervical vertebrae. So in order to put the screws, avoiding damage of these delicate arterial or nerve structures. Here we have a picture in which we are exercising with the collocation of these screws in the cervical segment of the spinal cord. If you combine these models, I have also made these models for training of young brain surgeons or residents in neurosurgery. These are very useful because they are mobile, they are articulated, and also they are made in a 1:1 style. Someone asked me if they are made in printing 3D. Not. These have been made with silicone molds, and they are made of resin. So this is another injection of the anterior cervical supply of the spinal cord. Look, these arteries are very thin, very small arteries, and if you inject them, you can make a differentiation between the arterial supply and some small branches that are coming from this anterior cerebral, an anterior spinal artery, cervical anterior spinal artery. So let me show you another beautiful pictures of the spinal cord. This is cervical spinal cord. This is the spinal ganglion, the posterior and anterior branch, cranial, cervical nerves. And this is another picture to show you this anatomy. Here we have the anterior, posterior cervical nerves, and this is the vertebral artery. And this is the supply of the cervical portion. So let me show you this. I want to show you the posterior aspect of this spinal cord and the wonderful view of the veins. I want to show you. As you can see, these kind of injection are very useful to learn, to know the venous drainage and arterial supply to the spinal cord. So in this, this is the anterior aspect of the lumbosacral segment of spinal cord. This is the Adamkiewicz artery. And here we can see the posterior spinal artery. This Adamkiewicz artery in the conus medullaris trifurcates into posterior spinal arteries, and the other one goes with the filum terminalis. And this is also a very nice short video to show you the corticospinal tract. The corticospinal tract. Many anatomists deny the existence of the pyramidal decussation until 1835, when Cruvelier traced the pyramidal bundles to the opposite side. Here we have the pons and the corticospinal tract descend and crosses to the opposite side in the medulla. Some of these fibers descend in the same side, in the ipsilateral side. This is Albert Adamkiewicz, who studied very nice the arterial supply to the spinal cord. But he also said that venous anatomy is not easy to define. So he defined very well arteries, but veins could not make a good, nice description of the system, the venous system, because of their variations. So what I am doing is to extract via a longitudinal midline posterior incision from the occiput to the sacrum, and anatomic dissection was performed until reaching the vertebral lamina. Laminectomies were performed from C1 to L5. The spinal nerves were cut with care so as not to lesion the dura. Here we have the spinal cord covered by dura mater. And look, this is also a very nice picture, video. Red natural latex was injected into the Adamkiewicz artery under moderate pressure and close visual inspection to avoid contrast extravasation. The injection was continued until latex filled distal small caliber arterial vessels, including the posterior spinal arteries, Veins were injected with blue natural latex. This is the Adamkiewicz artery. The great anterior radiculomedullary artery. This artery is located in the anterior aspect of the spinal cord, where it took a characteristic hairpin. The preoperative localization of this artery is very important in surgical procedures. This is the great anterior radiculomedullary artery. This is the Adamkiewicz coming from the highest level that I found in 50 spinal cords. This was coming from T3. And this is the lowest level in which I found this artery. It arises from left L2, lumbar 2, the lowest in 50 spinal cords. This is a really nice picture, beautiful picture of this segment of the spinal cord. In here we can see the cauda equina, and if I displace these nerves, look the lateral aspect of this spinal cord, and here we have the Adamkiewicz artery, and this is the posterior spinal artery, and I found also the great posterior radiculomedullary artery. This is some features in this in the arising of Adamkiewicz artery, and some variation, but what it was very important to know about the great posterior radiculomedullary artery, because this artery was denied for some authors and was denied also maybe for 4 or 5 authors. Understanding the basic vascular anatomy of the spinal cord is of utmost importance for imaging interpretation and endovascular and surgical management of a spinal cord vascular malformations. Here we have the posterior aspect of this spinal cord. As you can see, in the posterior aspect, the arterial supply is very thin, very delicate, and the existence of a great posterior radiculomedullary artery has attracted little attention and has been a matter of debate. Various authors postulate such a vessel like this one, but others do not mention it or even deny its existence like these others. Also, Domis in 1980 denied the existence of this beautiful artery. According to Jellinger, a large posterior radicular artery is seen caudally in about 75% of instances, but its caliber does not approach that of the large anterior vessels, diameter 350 and 500 micras. Its height is more caudal than that of the anterior radicular magna artery. This is the great posterior radiculomedullary artery. And nowadays, we are very sure about its existence, this beautiful artery, the great posterior radiculomedullary artery.
This is a great posterior radiculomedullary artery. It is coming along to the 12th thoracic nerve root in the right side. This artery makes a curve and goes to the posterolateral aspect of this spinal cord. Then returns to the posterior aspect between L3 and L4 nerves. Great posterior radiculomedullary artery.
The artery of Adamkiewicz in the spinal cord specimens was injected with colored latex. This is the latex into these beautiful spinal arteries. And let me show you after displacing these cranial nerves.
Here we have the posterior spinal artery that is coming from the Adamkiewicz artery.
This is a nice anastomosis between great posterior radiculomedullary artery, as you can see in this picture. Here we have the great posterior and this branch that is coming from the Adamkiewicz artery. So these two arteries, the great anterior radiculomedullary artery and the great posterior radiculomedullary artery, are making a very good anastomosis between them.
This is the posterolateral aspect of this spinal cord. Here we have the posterior spinal artery. This artery is going to make a beautiful anastomosis with the great posterior radiculomedullary artery.
This is another short video.
Let me show you in this video a very significant feature. So in this side of this spinal cord, the left side, we don't have an anastomosis between the posterior spinal cord with the Adamkiewicz artery at the conus medullaris.
In this spinal cord, there was not a great posterior radiculomedullary artery. Instead, there were several radicular arteries. These are the arteries. A variable number of radicular arteries originating from segmental arteries of homologous vessels make arterial contributions as lateral feeders along the course of the spine. These radicular arteries are small but differing calibers. Most of these radicular arteries supply nerve roots, the dura or the pial plexus. Only a few of these radicular arteries specifically provide arterial supply to the collateral network of vessels supplying the spinal cord. These vessels are specifically termed radiculomedullary arteries. This artery was identified in 72% of spinal cord specimens. This total includes specimens in which unilateral and bilateral great posterior radicular artery were found, as well as a single case in which 3 GPRAs were evident. In 26% of the specimens, a unilateral left-sided GPRA was present. A unilateral right-sided GPRA was present in 22% of the specimens, as you can see in these pictures. In 22%, bilateral GPRs were present. Like in this case, this is in the left side and this in the right side. The distribution was in this manner, and there is no doubt about its existence. GPR is coming from left T9. Look, this beautiful and very important artery. So let me show you this short video of spinal cord dissection. This is the end of the spinal cord, the conus medullaris. This is arachnoid. And then we have some arteries in here. I am dissecting the cauda equina to look the anterior roots, nerve roots. Continue with this dissection. All of these dissections and the study has been made in the Forensic Sciences Institute here in Mexico, Mexico City. So this is another beautiful video. Here we have the anterior spinal nerve, anterior spinal vein. In the anterior aspect of the spinal cord is very well defined this vein, but in the posterior aspect is difficult to define. I continue with the injection of this blue latex, and sometimes I can reach the low thoracic part of the spinal cord. Sometimes only the lumbosacral segment of the spinal cord. Look the variability in the venous drainage of these two spinal cords. In this video, we have too many drainage veins, but in the superior video is very well defined the venous drainage. Now we are doing a study about the variability of venous drainage of the spinal cord, and we want to define the specific anatomical variation, maybe to make classification of this venous drainage. I think this is really important for some specific specialties in neurosurgery, Posterior spinal vein, 1.48 millimeters. This is the bigger I have found. And look the anatomic variation of this venous drainage. It seems like malformation, venous malformation, but it is not. It's only a variation in the anatomic aspect of this venous drainage. This study was published in American Journal of Neuroradiology and was made with the great support and observations of Dr. Professor and my friend Juha Hernesniemi, and also Juan Small from Massachusetts. And this was published also in the first page of this American Journal of Neuroradiology. That's why I'm very proud about the study of this study of the spinal cord. Sometimes when you are doing an observation or a study of brain arteries, you can see, if you watch this picture, you can see a posterior communicating artery, a fenestration in this posterior communicating artery. But you cannot see in the other side. When I put this specific posterior communicating artery, very small, look the fenestration in this posterior communicating artery. Look the branches that are coming from this very small posterior communicating artery. So this is the importance to know, to dissect, to know these arteries. Again, this is the lateral aspect, the superior cerebellar artery, the third cranial nerve, posterior communicating artery, hypoplastic, but it doesn't matter if it is hypoplastic or not. Look, the great number of branches that are coming from this small artery. This is really a beautiful feature. So I have been making also a dissection of with a specific staining. This is known as Mulligan staining. And look what you can do with this technique. You stain with this technique only gray substance, sometimes in blue color, sometimes in a brown color. Let me advance the video. And the advantage of this kind of dissection is that for the comprehension of the deep structures of the brain, this is really useful. If you want to know the anatomy of relationships between the ventricles, the basal ganglions, the brain stem, the importance of this staining is you can see much better the gray substance, like in this case. So really, really beautiful. This kind of work, especially for students, residents, or young brain surgeons. So again, the musician, the painting, or another kind of arts requires great sensitivity for the development of his art. In the same way, the neurosurgeon requires knowledge of neuroanatomy to guide his hands in the delicate art of removing a brain tumor, of clipping an aneurysm, or treat another disease of the brain. So I want to give all my appreciation and care for my professor, Luis Delgado, who guided me in my first steps through the fascinating world of surgical neuroanatomy. Thanks, everybody. Thank you very much, dear Professor Yuha, Binshu, and Takashi Kon, also John Bennett. Thank you very much.
Thank you very much, Victor Hugo Perez, for this amazing lecture. Wonderful anatomical specimen dissections and totally new areas in the spinal cord. Very beautiful dynamic injections of the arteries and veins. So this is something very special, and I think this work is extremely valuable for neurosurgeons all around the world. So it was a really excellent lecture. Thank you very much. It is very difficult to discuss all the anatomical details, because in this more than 1 hour lecture, it was compact lecture, and so we learned a lot, repeated a lot, and learned some new things. My professor in anatomy, Giant Thundery in Zurich, used to say that medical study is a lifelong study, and anatomy even more. And this is certainly true. Victor has been 31 years in anatomical research and continues, and has done excellent work. We can also imagine how much work these all beautiful pictures and specimens need. For example, to open the whole spinal canal and then make injection. This is huge number of work. So thank you very much. We learned a lot.
Thank you, Dr. Yuha.
Thank you, Victor. I have a good news for you. So tonight, your presentation was so successful that the audience is more than 2,000.
Wow.
2,071.
Wow.
It's quite a number. Thank you.
Thank you
for your very
China.
beautiful.
This is only China.
Yeah, this is a very beautiful presentation. Thank you so much.
Thank you, Dr.
I also learned a lot. I'm sure I will play back your video again.
Thank you, dear professor and friend Shubin. This is a real honor for me to be invited with all of you. I am very proud to be your friend. Thank you. Hope to see you someday here in Mexico.
Thank you. Yeah.
No beautiful beaches that we have here. Once
for sure. Yeah.
Once COVID
after the pandemic. Yeah.
go away. Yes, thank you so much.
Thank you.
Maybe, Subin, you can ask the Chinese colleagues, neurosurgeons, if there is a need for more anatomical lectures, more specific lecture, because this was an overview, extremely compact overview and very detailed view, but then you might concentrate for some even more detail. So we ask if there is a need for more lectures.
Yeah. Actually, next year we will host some international conference. If it's possible, we will invite Victor
Oh, actually,
Yeah,
to come to Shanghai. Yeah.
well, he's been to China before, right? Victor?
Yes, I met Dr. Minshu maybe 2 or 3 times.
Yeah.
I was invited by Dr. Yuha, and it was amazing. For me, this is really a honor. So, as you know, I am very grateful with the Committee of Neurosurgical Anatomy. I am involved with this committee, and I have the responsibility to continue to make this kind of anatomy. There is something very and really important. We can learn anatomy in pictures, videos, and books, but it's not easy to make a research specifically, for example, in the arterial supply or venous supply of brain or spinal cord. So we have to be very, very meticulous to find interesting features for the brain surgeons. And neuroanatomy is like a language, and it's a universal language for all the world. So that's the importance of neuroanatomy. If I say that here in Mexico, branches of the anterior communicating artery, this is understood by all the colleagues around the world. That's the importance of neuroanatomy. So I really grateful with Dr. Vladimir Benes, which introduced me to this fascinating committee of neurosurgical anatomy. And I am involved also with the committee of awards for young brain surgeons. This is really a honor for me here in Mexico. Thank you very much for your kind words, friend Vinshu.
Okay. I'd like to show what Victor is starting in a couple of weeks. This is a series in neuroanatomy in Spanish, and I was going to ask Ben that maybe we should do one in English so that we can translate it into Chinese and Japanese also. So I'm very encouraged by the response today, and I think you are too, Ben. So I think we'd like to arrange that shortly in the future. Well, we'll talk to Victor about it after, but I think we could do a series in English. And I think we'll probably get the same response from the Chinese and Japanese communities. What do you think, Ben?
Yeah, no problem.
Okay, I'm sorry there. Yes, we'll let you know, Ben. Let's see. Okay, any more comments or someone want to say hello to Victor? Is Vlad, are you there still? Vlad Benes from Czechoslovakia. Manuel, are you there? Perhaps not. Okay, very good. Okay, anything else, Yuha?
I think the most comments I have seen, the excellent comments. Thank you very much, Victor, for excellent lectures. And certainly there is a need for more of these kind of anatomical lectures. Like Victor said, it is international language, so everyone looking at these specimen dissections will learn a lot. And like Subin said, by repeating them, to learn anatomy is repeating, because the lifetime is too short to learn everything. So I thank you, everybody, and wish you good day or good night here in China.
Okay.
So thank you very much for involving us. And then next week, next Friday, we meet again.
Okay, very good. Thank you very much, Juha. Thanks for the
Thank you very much.
Thank you.
Thanks, Ben. Thanks, Takashi, and thanks everyone for coming.
Thank you very much, Dr. Radames. Thank you very much, Dr. Reinaldo Chacon, Montoya Olervides, and all of you. Thank you so much for coming to this lecture. Have a nice day.
Gracias, Victor. Victor, thank you.
Congratulations.
Gracias.
Very nice meeting. Congratulations.